This is a version of a talk that I gave at the inaugural Society for Clinical Psychology meeting in 2024. And like I said, I'm going to try to use the channel to either practice talks, or also now I'm editing a little bit to upload maybe talks that I gave at smaller conferences or venues where other people don't have a chance to see me. And this talk is very different than other ones I've ever done, because it is really about the need to reconceptualize our work and our treatment work. Specifically, the context for this talk, really the reason why I wanted to do this, is because I see a perception in my work and the work of other people that psychotherapy research and research on interventions in a way has like stagnated. So after decades of psychotherapy research, we can always say that like psychotherapy is effective, right? It's very effective if you compare it to weak controls like waiting lists, but it's also effective if you compare it to stronger controls. Like, unfortunately, as effective as it is in this kind of comparative way, if people undergo psychotherapy, roughly for depression, I'm going to use that as an example, roughly 50% of them will respond in their symptoms. If you look at the rate of remission, it's a lot lower than that. It's closer to 30 to 40% of the people that remit. Many of them will relapse. And I also think that contributes to the sense of stagnation, that we haven't found therapies that on average are effective than others. The burden of disability or illness attributable to mental health hasn't decreased. There's a lot of people in our society that go untreated or undertreated. And the way that we allocate people to treatment is sort of based on whether treatment is available around you, which it usually isn't, or trial and error, which we perceive to be bad. In this context is when we usually bring in like innovation, right? Like new solutions that promise to use technology or advances in science to make novel contributions to intervention research. My basic thesis is that a lot of the promises to use innovation to improve treatment outcome are often empty, and maybe from the start could be evaluated to be empty. By empty, I mean like they actually don't have the capacity to achieve the aims that they are stated. I'm going to give you the way that this talk progressed. I'm going to give you a couple of examples of quote unquote promising research programs, including my own work, where I actually think that from the get-go, there's been an issue in what the promise is. I'm going to try to, along the way, identify some commonalities of these promising, innovative research programs. And then I'm going to try to end it with a recommendation for kinds of quote-unquote boring research that I actually think have a greater potential to help us in terms of the public health burden of psychopathology. I think for especially if you're a psychologist or in psychiatry, arguably the biggest example of a promise that fails to deliver is biomarkers. So I have a quote up here, but it's a typical quote that you get on a paper reviewing biomarkers for depression. And the quote says here, in the study, there were a bunch of potential biomarkers, and it says, it's clear that although much work is needed, establishing a relationship between relevant biomarkers and depressive disorders has substantial implications for reducing the burden of depression at an individual and societal level. So like, a pretty big claim to improve outcomes. I'm not saying that this is stupid, right? That the idea of looking for something like biomarkers is dumb, right? Of course, mental health problems are happening in our bodies and our brains. So our bodies and our brains are sort of naturally places to look for clues. I think one of the unfortunate things about biomarkers is that they're so seductive and they're so reductionistic that it's very easy to invest a lot of money into research programs or a lot of time into research programs and then be very misled. Arguably, the issue with the serotonin transporter theory of depression is probably the biggest example of this, right? And all the work around that has either failed to replicate or just really never materialized. To my knowledge, there are no replicable biomarkers of something like, for example, treatment outcomes, except things that, for example, help you rule out medical illnesses like hypothyroidism. I think one of the things I want to say about this idea of biomarkers, especially biomarkers that are expensive, is that the solutions that promise to use them are not very scalable. So in the United States, roughly 35 to 51% of people meet the criteria for depression by age 30. This is in prospective studies where people are assessed repeatedly over the life course. A couple come from the United States. There's a couple from other countries. What they suggest is that when people say, oh, 20% of people meet the criteria for depression over their lifetime, that's actually an underestimate. Most people, if you ask them repeatedly, fall into depressive episodes, right? This is very easy to reconcile with the idea that depression is on a continuum, and it explains why for some people depression is like this. They consider depression like a highly debilitating chronic and recurrent illness, and other people like Marty Seligman have called it the common cold of psychopathology, and we all kind of know what that means, right? These are symptoms that are very common. I actually really like the analogy to the common cold because I think it helps us to think about how the common cold is treated. If you've had the symptoms of the common cold for less than a week and you show up to the doctor, they're not going to start doing expensive biomarker testing from the get-go, right? What the doctor does is they basically kind of assume that you have the illness that would cause those symptoms, the most common one, i.e. the common cold, and then they tell you the recommended treatment, which is watchful waiting, and then maybe some over-the-counter medications for symptoms that are a little unmanageable. If you've had the experience of not having those symptoms get better and then you go back again, even then they don't do very fancy biomarker testing if you're not considered a person at risk. They assume the next most common cause of infection, which is a virus or a sinus infection or some complication like that. It's after that level of trial and error that has progressed that they may start doing more expensive biomarker testing. What I think this thought exercise does to me is, first of all, it confirms that even other areas of medicine don't jump into biomarker administration for symptoms that are rather common. I think it also underscores the idea that we think of trial and error as this really bad thing. So we want a biomarker that will immediately determine what treatment you get. But, trial and error through treatment response can give us information about what is happening, much in the same way that it does for the common cold. There are other examples that I think make the case. So my colleagues and I started doing work on predicting treatment outcomes, not using biomarkers, but using psychosocial measures, and using machine learning methods to do that. The quote that I'm showing you here is from our first paper in 2014, and it says, this approach can enhance therapeutics, help us select the best available treatment, and not only does it do that very practically, it also gives quantitative estimates of the benefits that can be expected when such an algorithm is implemented. That paper, the last time I checked, it was cited over 500 times. Similar paper by Helena Kramer is cited 100, 200 times. Since then, there's been maybe 20, 30, way more studies using machine learning methods to reanalyze data and try to pool together potential predictors of outcomes. But to my knowledge, only one team has prospectively tested a machine learning algorithm to guide treatment. So that's Jamie Delgadillo's team. Michael Constantino's team prospectively tested an algorithm to assign people to therapists. So that's just basically 2 studies on the potential of these approaches. In one of them, for example, in the study by Jamie, the machine learning driven assignment had an effect on recovery and depression, but not anxiety. It wasn't super robust. So it's not like even the work that has been done is revolutionizing healthcare. There's still a lot to do. I think one core issue in this kind of work is that benchmarking simulation studies suggest that you need huge sample sizes to do this kind of work, and it's just very difficult to get those kinds of studies funded. Similarly, much in the same way that I was talking about the promises of machine learning, I've also talked about the promises of technology to deliver psychological treatments to people most in need for them. The reason to do this is obvious. Almost everybody in the US has access to the internet. These internet-based treatments are roughly equally effective to one-on-one therapy. And so there's this assumption that it can reduce a lot of barriers, right? It can increase treatment uptake, it may reduce health disparities. You may be able to integrate technology into healthcare. And some people have even said that maybe it addresses some barriers to treatment that come from the individual, right? Maybe you're embarrassed to talk to somebody else about your problems, but using an app for educational purposes or a book or something like that would be better. Our work suggests that although there's still a potential and a promise for technology-based interventions, this promise has largely gone untested. So, for example, we had a systematic review where we identified that there were at least 41 internet-based CBT programs that have been tested up to 2023. 85% of those, most of them, were not made available to the public. My colleague Akash Wasil has looked at this from the commercial end, looking at the marketplace of mental health apps. Most of the ones that are on the App Store are, of course, not tested in randomized controlled trials. But even just looking at the content that they have, most of them don't have evidence-based content. They're basically sort of glorified meditation apps. Our work also suggests on the front of health disparities that the studies do a very bad job with reporting sociodemographics like race and ethnicity. And of course, in terms of reporting, the work also suffers. Some formative work that we have right now suggests that the things that are barriers to one-on-one therapy, like, for example, thinking that you don't need treatment, those things are also barriers to using digital or technology-based interventions. So again, this is sort of an area from an example from my work where there's a lot of excitement, but maybe there wasn't a lot of formative work exploring and criticizing that excitement. I'm going to give you an example now removed from my work. Is the case of De Barlow's Unified Protocol. For those of you that don't know, this is a CBT-based manual that is supposed to apply to clinical presentations that cut across disorders, like instead of social anxiety or depression, it's like for emotional disorders, which I would call internalizing. In their 2017 trial, Barlow said the Unified Protocol could simplify training, address concerns about eligibility, and overall increase access to psychological treatments, kind of like very promising. They also have found some work that compared to single disorder CBTs, the Unified Protocol reduces neuroticism, temperamental vulnerabilities to psychopathology. In their study, it increased treatment completion, and they've hypothesized that because it cuts across diagnoses, it may be better at reducing comorbidity, right? Comorbid symptoms from treatment. If you've been following the thread and the negativity, right, this falls short of the promise. So the work that Barlow's group themselves have conducted suggests that the Unified Protocol is no better than single disorder CBT for primary anxiety disorders. Stephanie Jarvis-Steele published a reanalysis where the Unified Protocol was not better than other CBT in reducing comorbidities, so that's kind of one of its claims to fame. USMA in 2021 published this, what I thought was a great, excellent study comparing group-based Unified Protocol treatment to care as usual in Spain, which involved the potential for medication, a little bit of CBT-light work. In their study, which was larger than Barlow's and in which Barlow's was also involved, there were no differences, statistically or clinically significant, in the changes in personality, mainly temperament, but also extroversion, between the UP and treatment as usual. So that has failed to replicate. Treatment completion was actually slightly higher in treatment as usual than the UP, although the effect was not statistically significant. And in the long-term outcomes, the differences favored the UP, but were not statistically significant. So one of the things that is difficult with this innovative research is that you make a strong claim and you find evidence for this strong claim. A lot of the times there's no great incentive to actually interrogate this claim, which in light of the replicability crisis is a really big problem to some of the inferences that we can make from this treatment research. So I think that's an issue that I pick up in this literature. To me, really, the original sin of the research on the Unified Protocol is that it's addressing a problem that the stakeholders maybe were not bringing up. So Becca Stewart and Diane Chambliss did work on barriers to disseminating empirically supported treatments, usually found in treatment manuals. And in their qualitative work or in their quantitative work, they didn't find that people were saying, oh, there's just too many manuals, if only there was just one by David Barlow. The reasons clinicians don't use CBT or evidence-based practices or manuals don't have to do with there being too many of them, have to do with them relying on the therapeutic alliance, have to do with them thinking patients are not representative. This work is not addressed by the UP. A person that's doing psychoanalysis, to put it bluntly, isn't going to look at the UP and say, oh, actually, I'll do that. I won't do other CBT, but this kind of CBT I'll do. And so I think it's really addressing a question that was not answering. So hopefully this talk is short enough that maybe I don't need to summarize, but I think a lot of the stumbling blocks in this innovative research is they ignore how prevalent depression is. So the solution needs to be really scalable. They ignore the replicability crisis and have usually low incentives for poor rigor. And I think a really big one is that people set out to discover something really cool and then figure out after the fact how they can disseminate it. So dissemination potential is treated almost like as an afterthought rather than the question of interest. I think one boring, and I've been beating this drum for a while now. I know other people have, like Pim Kuipers, for example. One thing that could be of interest in the field is to study the idea of combining treatments more. So we don't like trial and error, but that is how people get better in the real world. Naturalistic data suggests this. WHO World Mental Health Survey suggests this. Although there is a little bit of work on randomized controlled trials of step care, we still don't know what is the most effective way of keeping people engaged when they will need multiple treatments. What's the most effective way of sequencing treatments? What are the role of preferences? So there's still a lot of practical questions about how you go from failing self-help to having a partial response to psychotherapy to possibly doing well on medications to maybe needing something else to relapse prevention. So these sequences we don't study. We often do this RCT where it's just one treatment versus another, and we need more work on the combination of treatments. I think another area is computational modeling. So these treatment studies that are RCTs, whether they're digital or not, they're expensive and cumbersome. I think a lot of us do them because we were raised in this tradition where you're a treatment researcher, so you do a treatment study. But not every question needs to be put to an RCT, and certainly not an efficacy one, especially for things that are either well-established or that we know very little about. So to give an example that's familiar to all of us, when the COVID pandemic hit, experts were making recommendations, a lot of the time based on things like simulations, computations, and discussing sort of plausible outcomes of strategies like hand washing, vaccination, and social distancing. There's a little bit of this work on psychotherapy in the process outcome research, but there could be a little bit more in terms of thinking about smart ways of allocating people to treatment and differential treatment strategies. So I hope that gives you a sense of the of my critique of quote unquote innovation in psychotherapy research. And now I'm not saying drop everything and everybody only do computational modeling or combination treatments, or that we need to replace this innovation by biomarkers and machine learning and streamlining. Now we need to replace it with computational modeling or combining treatments. I just really want to put a spotlight on how our goals don't often align with our methods. And I think hopefully the discussion of these examples maybe sheds light a little bit more on the importance of doing formative work prior to embarking on these very expensive treatment studies or expensive biomarker studies that maybe don't really have as much of a potential as we would like them to. And I appreciate you listening, and I'm happy to take comments on Twitter or the comment section.